Good morning everyone. I am Dr. Vijeta and today we are going to discuss gonadotropin treatment. I have taken this from the ASRM article which is named Use of Exogenous Gonadotropin for Ovulation Induction in an Ovulatory Woman and from Sparrow. In this, we will be discussing the indication of gonadotropin, the pre-treatment evaluation, which all pre-treatment evaluation need to before starting gonadotropin, the treatment regime like step-up regime, step-down regime, and the monitoring of ovulation induction. How will we monitor ovulation induction by serum estradiol, USG, or other methods? So these things we will discuss in this lecture. As we all know, in IVF, we will use gonadotropins for formation of multiple follicles. Apart from that, in induction of ovulation, we can use gonadotropin as a primary treatment in case of hypogonadotropic hypogonadism or after the failure of other medication like letrozole or clomiphene citrate. So these are the indication for using gonadotropin in an ovulation. Let's discuss the role of gonadotropin in detail in ovulation induction. As we all know, three type of anovulation, that is WHO type 1 in which LH and FSH is low and also the estradiol is low, which is known as hypogonadotropic hypogonadism, and this is the primary indication of ovulation induction by gonadotropin. The second one is WHO type 2 anovulation, with the most common example is PCOS, in which FSH and estradiol are normal range. That's why it is known as eugonadotropic eugonadism. And in this, if we fail to ovulate the patient by using letrose or clomiphene citrate, then the gonadotropin can be used as a second line, not as a first line. And in the third type of anovulation, that is when there is both FSH and LH is high but the estradiol is low, that is in case of POI, will require oocyte donation. So the role is in primarily in hypogonadotropic hypogonadism, and the second is eugonadotropic eugonadism when the oral medication fail to ovulate. The third is unexplained infertility, as in ASHRAE guideline that you can use gonadotropin for ovulation induction in unexplained infertility, but you should be cautious about the OHSS and multiple gestation. And IVF and ICSI, it is very much used for the multiple follicle development. Let's quickly discuss hypogonadotropic hypogonadism and how gonadotropins help in this condition. So hypogonadotropic hypogonadism is the low hypothalamic gonadotropin releasing hormone, or either the pituitary LH or FSH are low. So it can be due to the hypothalamic cause or due to the pituitary cause. Both will be present with the hypogonadotropic hypogonadism. So the causes of hypogonadotropic hypogonadism can be congenital, acquired, or idiopathic. Congenital, for example, Kallmann disease. Acquired include the anorexia nervosa, excessive chronic physical exercise, low BMI, poor nutrition, hyperprolactinemia also decrease the GnRH. So it can cause hypogonadotropic hypogonadism and the medication. And idiopathic when the cause is not identified. So let's discuss the treatment of these conditions. The first line treatment for the acquired, that is the secondary causes of hypothalamic amenorrhea or hypogonadotropic hypogonadism, is the behavior modification. Let's come to discuss the clomiphene citrate. Clomiphene citrate will not be used in hypogonadotropic hypogonadism, as their main aim is to increase the endogenous LH and FSH. But in this case, hypogonadotropic hypogonadism, the endogenous LH and FSH is low. So this will not increase the endogenous LH and FSH. Let's come to the main treatment. Main treatment is gonadotropin. So these should include both LH and FSH. The FSH will cause the folliculogenesis and LH will cause the steroidogenesis. Let's discuss the detail. So FSH will cause the proliferation of the granulosa cell and the follicle growth, and LH will stimulate the theca cell to produce the androgen, and which will be aromatized to the estrogen in the granulosa cell. Thus, it will promote the follicles development. So, these patient hypogonadotropic hypogonadism will both require LH and FSH. After discussing the role of gonadotropin in hypogonadotropic hypogonadism, let's come to eugonadotropic eugonadism. The most common cause of eugonadotropic eugonadism is polycystic ovarian disease. And the first line of treatment for ovulation induction in polycystic ovarian disease is first lifestyle modification and induction with clomiphene citrate or letrozole. Letrozole is the first. But if the patient did not respond to clomiphene citrate or letrozole, then we can proceed to gonadotropin. As the gonadotropin is invasive, patient need to take daily injections, and also there is increased risk of OHSS and multiple gestation pregnancy. So we need to be extra cautious before using the gonadotropin. As we know that the PCOS has low or normal FSH, but they have increased LH. So only FSH injection like follicular can induce the ovulation in patient with PCOS. But if we add LH, it will not be harmful to the patient. Let's now discuss pre-treatment evaluation which is required before starting gonadotropin. So before starting gonadotropin, as it will require daily injection, we should confirm that the uterine cavity is normal, the fallopian tubes are functional, that is by HSG or any other method, and the semen analysis is normal or not, and also the routine infertility basic infertility workup which include thyroid function normal or not, and in patient with anovulation to find out the cause of anovulation, the prolactin levels to rule out hyperprolactinemia is also required before the treatment of gonadotropin. These are the pre-treatment evaluation. These also require the normal investigation like blood group, CBC, HP, LC report, IgG rubella, and the blood sugar levels. Before starting gonadotropin, it is very essential to counsel the patient attendant and patient about the instructions, the cost of gonadotropin, the success of gonadotropin, the risk associated with gonadotropin, and the frequency they need to come to the clinic for the monitoring of gonadotropin. They should know the injection, how to inject gonadotropin, and they should be familiar with the medication which are prescribed. So these all are very important before starting gonadotropin. Let's discuss the dose and duration of gonadotropin used. So it will vary among women that some patient will require a low dose and some patient will require higher dose of gonadotropin, and it also vary among the cycles. In some cycles the patient respond to a low dose, in another cycle of the same patient they'll respond to a higher dose. So although there is a direct relationship with the body weight and the dose requirement, but we cannot predict it reliably, and the safe and effective ovulation induction with gonadotropins depend on the experience and the clinical judgment of the treating clinician. Now coming to the treatment regimes. So the treatment regime, whatever treatment regime we will use, we should consider the goal of our treatment. That is either unifollicular development or we need a purposeful superovulation. We'll first discuss the step-up treatment regime. In step-up treatment regime, we'll start with the low dose, that is 75 international unit of gonadotropin daily, and we'll give it to 4 to 7 days. And after 4 to 7 days, we'll do a estradiol level and or a transvaginal ultrasound to measure the response of the treatment. And after that, we'll know whether to increase the dose or we will maintain the same dose. So this is the graph in which this is the y-axis showing serum FSH level and x-axis showing the gonadotropin days of gonadotropin administration. So initial days we will give the lowest dose, and then after seeing the response either we will maintain the same dose or we will increase the dose according to the response. So this is the step up treatment regimen. And once the lead follicle, that is the dominant follicle, reach 16 to 18 mm, we'll give the HCG, and then it will ovulate around 36 to 48 hours later. So this is the step of regime. Coming to the next regime, that is low slow treatment regime. The name itself defines the regimen, that is low dose, and will slowly increase the dose. Why slowly? Because the OHSS risk, multiple gestation risk, and the frustration which is caused by the cancelled cycle, because multiple follicle will develop, then we have to cancel the cycle. So this will involve what? The low dose will be given till day 7 to day 4, day 1 to day 14, and then we gradually increase the dose, and then 14 to 21, and then gradually further increasing the dose. So this will involve a small increment, so the time for the stimulation will be longer. So this is known as chronic low dose step up protocol. This will require a longer duration of the stimulation as we are increasing the dose very slowly. So this is low slow treatment regimen. We will discuss step down treatment regime in our next lecture on this topic. I hope you enjoyed this lecture. Thank you.